Is it Kawasaki disease?
Right.
Okay, this patient has fever for 5 or more than 5 days plus conjunctivitis, mucositis, rash, extremity changes consistent with Kawasaki disease, non-specific gastrointestinal vomiting, diarrhea, or respiratory cough condition. Symptoms may precede the development of mucocutaneous findings, as seen here. Lab evidence supportive of systemic inflammation in KD include leukocytosis and thrombocytosis. As seen in this case, sterile pyorrhea, which presents urethral inflammation, is also classic and characterized by urinary WBC with no bacteriuria. Although mild anemia is common, patients' elevated hematocrit may represent hemoconcentration from poor fluid intake. Treatment of KD with IVIG, presumably due to it's an anti-inflammatory effect. IVIG decreases the risk of coronary artery aneurysm, which is the highest in patient with delayed treatment. Therefore, IVIG therapy should be initiated within 10 days. Within 10 days of the symptom, in all patients with KD, aspirin is administered for its anti-inflammatory and antiplatelet effect, but it does not affect aneurysm development. Yes. Kawasaki disease is a medium vessel vasculitis, usually affects children aged less than 5. Incidence increase increase incidence in East Asian ethnicity. Fever 5 or more than 5 days plus 4 of the following: conjunctivitis, bilateral non-ulcerative conjunctivitis, mucositis, in injected fissure lips or pharynx, strawberry tongue, cervical lymphadenopathy, one or more than uh, nodes for more than 1.5 centimeter, one or more than one node, more than 1.5 centimeter, rash, perineal erythema and desquamation, polymorphous, generalized erythema and edema of the hands and feet, periangual desquamation. Lab finding increased platelet and blood and WBC, decreased hemoglobin, increased acute phase reactant, C-reactive protein increases, TILT, sterile pyorrhea. Treatment IV, IG, and aspirin. Complication coronary artery aneurysm and ventricular dysfunction. Okay. Okay, this patient has severe this patient has severe lower extremity pain. This patient has severe lower extremity pain by passive stretch of the calf muscle, passive movement of the ankle and the toes, passive movement of the ankle and the toes. Given his likely crush injury, leg pain under dashboard bruising, and the use of antiplatelet medication, which may cause occult bleeding, which may cause occult bleeding. This presentation is concerning for acute compartment syndrome. This patient is concerning for acute compartment syndrome of the lower leg. Compartment syndrome is a limb-threatening condition caused by increasing pressure with an closed fascial plane. Enclosed fascial space that limits the perfusion of the muscle and nerve tissue. Compartment syndrome is frequently associated with long bone fracture, but other cause include compartment syndrome is frequently associated with long bone fracture, but other causes include crush injury and arterial reperfusion procedure. Patients on antiplatelet therapy or anticoagulation are at increased risk. Severe pain, classically out of proportion of the injury that exacerbated by passive stress, is a classic early feature. Other features that have typically occurred later: loss of sensation, motor weakness, or diminished pulses. Although compartment syndrome can be a clinical diagnosis, not all features may be present early in the course. Pain medication may mask the symptoms. Surgeon may choose confirm the diagnosis and avoid necessary fasciotomy by measuring compartment pressure. Needle manometry, a delta pressure or diastolic pressure minus compartment pressure less than 30 is associated with compartment syndrome. And definitive management is emergency fasciotomy. Okay, this patient who fell while climbing stairs is unable to maintain knee extension and has a high riding patella on extreme. This presentation is consistent with patellar tendon rupture. This presentation is consistent with patellar tendon rupture, which may be caused by sudden forceful contraction of the quadriceps muscle trying to prevent a fall. Trying to prevent a fall. Trying to prevent a fall. These risk of a rupture is greater in patients with tendinous fragility, chronic kidney disease. Rupture of the extension mechanism of the knee can be categorized in relation to the patella. Quadriceps tendon rupture typically occurs at the tendon insertion on the patellar superior pole of the patella may right low patella basa, indicating an intact connection to the tibia. A palpable defect may be felt superior to the a palpable defect may be a palpable defect may be felt superior to the patella. Patellar tendon rupture typically occurs just distal to the patellar's inferior pole. Because the patella is pulled proximally by the quadriceps, it may ride low patella alta, and a palpable defect may be felt inferior to it. Other typical symptoms include rapid swelling, large effusion, and an the inability to actively extend the knee against the gravity or maintain a straight leg while fixing at the hip. The diagnosis is typically made using examination and X-ray finding surgical repair of the ruptured tendon is required. Oh, Ottawa ankle rule. Ottawa ankle rule. Ottawa ankle rule is never MRI, always X-ray. Why you are thinking it is either X-ray of the ankle or X-ray of the foot? আচ্ছা, okay. Ottawa ankle rule first. Ottawa ankle rule, X-ray of the ankle. X-ray of the ankle is required if X-ray of the ankle is required if pain in the malleolar zone, tenderness at the posterior margin or tip of the medial malleolus, tender at the posterior margin and tip of the lateral malleolus, and unable to bear the weight. 4 steps. Extra foot is required if pain in the midfoot zone and tenderness. Pain in the midfoot zone and tender at the navicular bone, tender at the base of the fifth metatarsal, or unable to bear four step two on each foot. The patient, this patient has lateral ankle injury caused by forceful inversion of the foot, which commonly occurs with running, walking, or on uneven surface, descending stairs, or falling from height. Most ankle injuries are caused by sprains in which the ligaments are injured by the bones remain intact. Uncomplicated sprain are typically managed conservatively. However, orthopedic intervention may be required if a bony fracture is present. The ortho ankle rules were developed to determine which patients require imaging to rule out the ankle fracture. These rules have high sensitivity up to 99% for detecting fracture and can help to reduce the number for unnecessary radiograph. Plain radiograph of the ankle are indicated in patient with pain in the malleolus, pain in the malleolus in association with either point tenderness of the posterior margin or tip of the malleolus, and inability to bear weight after the injury four steps during medical evaluation, inability to walk to the examination room. Further management depends on presentation and X-ray finding. Immediate orthopedic consultation is indicated for any open fracture. In any open fracture or in those with evidence of neurovascular impairment. Okay. Why? Yes. Osteoarthritis, steroid is for inflammatory, like rheumatoid arthritis. These has role, but osteoarthritis steroid does not have that role. Sorry. Mm, okay. This patient has pain and stiffness consistent with early osteoarthritis of the hands. Osteoarthritis typically becomes symptomatic at age more than 40. Patients often report worsening of symptoms with extensive use of hand tools or other strenuous motor tasks. Opening jar osteoarthritis of the hands is primarily a clinical diagnosis. Distal interphalangeal joint is involved in classic bony enlargement at the distal and proximal interphalangeal joint. Haverdon or Boucher's note is pathognomonic and often associated with strong family history of this condition. Initial management of hand osteoarthritis stretching and strengthening exercise. NSAIDs reduce prostaglandin induce sensitization of the peripheral nociceptor and are effective for pain relief in patients with OA. Topical NSAID diclofenac are adequate for most patients. Oral NSAID are effective for but carry greater risk for toxicity. Yes, glucosamine is sometimes suggested for management of knee osteoarthritis, although evidence of its benefit is mixed. It is not well studied for OA of the hands, and any benefits is likely negligible. Is it temporal arteritis? Aortic aneurysm. This patient has this patient has typical features of giant cell arteritis, also known as temporal arteritis. Manifestation include jaw claudication, muscle fatigue, weight loss, and visceral visual disturbance. On examination, patients have scalp tenderness and decreased pulse over temporal artery, which may have cord-like feel. Many patients with GCA have associated with polymyalgia rheumatica with morning stiffness affecting the shoulder and hips. The ESR is generally markedly elevated, more than 50 millimeter mercury. A feared complication of GCA is permanent vision loss, which can develop up to 20%. Patients in these often sudden, painless, irreversible, sudden, painless, and irreversible. It is often due to anterior ischemic optic neuropathy from the arteries. Anterior ischemic optic neuropathy from the arteries. Another recognized complication, which has also been noted in 10 to 20%, is aortic aneurysm due to large vessel involvement. Patient with aortic aneurysm typically followed with serial imaging studies. Okay. Is it complex regional pain syndrome? I don't know how to diagnose it. Okay. What is the key feature in here? Okay, this patient has subacute severe unilateral limb pain with subacute severe unilateral limb pain consistent with complex regional pain syndrome, previously known as reflex sympathetic dystrophy. CPRS often presents with 4 to 6 weeks following trauma, fracture, or sprain, or surgery, possibly due to effects in the inflammatory cytokines. Although the exact etiology is not known, or exact etiology is not understood, it is characterized by burning or tingling pain out of proportion of the inciting agent. The pain does not follow a dermatomal distribution and is typically worsened by movement or light contact allodynia, which may lead point to reduced activity. The diagnosis of the CPRS based on primary clinical findings. In addition, the sensory changes, allodynia, hyperesthesia criteria, edema, pseudomotor changes, sweating, vasomotor changes, erythema, altered skin temperature, advanced cases, tropic changes affecting skin, nails, hair may be present, and patient may have motor weakness, contracture. X-ray often shows patchy demineralization, bone scintigraphy may show increased intake of the affected limb. Management of CRPS should emphasize exercise, physical or occupational therapy, patient education, comorbid depression, and anxiety should be addressed. Medication options include NSAIDs, anti-neuropathic medication, primary anticonvulsant pregabalin, TCA, bisphosphonate, and topical lidocaine or capsaicin may be effective. Okay, yes. trauma, fracture or sprain, surgery. Clinical feature pain, severe regional, not dermatomal burning or stinging. There may be edema, abnormal sweating, vasomotor changes, altered skin temperature, tropic skin, hair, nail changes. Diagnosis primarily based on clinical feature, X-ray, patchy demineralization, and bone scintigraphy. In case update of the affected limb, physical and occupational therapy, exercise, and medication, NSAID, anti-neuropathic medication, pregabalin, and TC. Okay, is it Colles fracture? Yes, dinner for different. Maybe. Okay, this patient with significant wrist deformity, distal radius fracture, significant risk deformity, distal radius fracture, Colles fracture, which commonly occurs after falling on outstretched hand, particularly in athletes and elderly patients with osteoporosis. Low impact falls characteristics finding include pain, swelling, dimensional deformity of the wrist. In addition, severely displaced fracture may result in neurovascular compromise. Therefore, careful assessment of pulse, capillary refill, and sensation is indicated. Dorsal displacement of the radius, as occurs in Colles fracture, can result in compression of the median nerve, which enters the wrist through the carpal tunnel and provides sensation of the lateral 3.5 digits and motor innervation to the thinner muscle. Oponensis pollicis, abductor pollicis brevis. Compression result is acute carpal tunnel syndrome. Symptoms including paresthesia of the affected digit and impaired thumb abduction by the abductor pollicis brevis. Furthermore, if compression occurs proximal to the tunnel, the palmar cutaneous branch of the median nerve The palmar cutaneous branch of the median nerve may be affected and leading to decreased sensation over the anterolateral hand. Okay. Yeah. Yes. Mm, Injury to the radial nerve at the elbow. Injury to the radial nerve at the elbow can cause weakness of the hand or finger extensor muscle and sensory loss over the forearm and dorsolateral hand. This is typically happens in supracondylar fracture of the humerus. Compared to the median nerve, the radial nerve is less likely to involve in the Colles fracture. Do you need further workup? Toddler fracture. Okay. Spiral fracture. The distal tibia can be ambulatory. Children age 3 or less than 3 are known as toddler fracture. These fractures typically result from a twisting injury during a low impact fall in the early walking years. A thorough history is essential. The thorough history is essential during initial evaluation because non-accidental trauma must be considered if the mechanism does not match the injury or if a spiral fracture occurs in a non-ambulatory child. However, if the patient fall after tripping is typical for a toddler fracture and the location of his bruising, scattered bruises on bilateral knees and lower legs, and is common in early walkers as they stumble while walking. In contrast, bruises on the face, neck, torso, buttocks are commonly associated with physical abuse. Typical fracture present with pain, limp, and refusal to bear weight. Pain elicited with ankle dorsiflexion or twisting of the knee. An ankle is opposite direction is characteristic fracture site. Tibial fracture site tenderness and leg swelling may also be present. Anteroposterior and lateral radiograph may be normal initially but show a hairline fracture as seen in this patient. Typically involves immobilization, pain control, additional workup. Okay. I I have done the same mistakes. That's why I'm waiting for your answer. Okay. In here, we need to differentiate based on the pulmonary function test. If the FEV1 and FBC is normal, if the FEV1 and FBC is normal, it is only pulmonary hypertension alone. But if FEV1 and FBC is decreased, then it is ILD. And in pulmonary hypertension, there is clear lung, and in ILD we know that there is velco like crackle. So that is the main two differentiating point. According to box, look at the box. In the box, pulmonary PAH, pulmonary arterial hypertension, there is clear lung, but in ILD there is velcro like crackle, and in PAH normal FEV1 by FBC, but in ILD there is decreased FEV1 by FBC, and DLCO in low in both cases. Okay, this patient has progressive dyspnea. This patient has progressive dyspnea and signs of heart failure, clear lung, elevated JVP, loud P2, elevated P2. This patient has right-sided heart failure, clear lung, elevated JVP, loud P2, peripheral edema, right axis deviation. She has a limited systemic sclerosis as evidenced by sclerotic tiling and fingertip skin tightening, Raynaud's phenomenon, severe gastroesophageal reflux, dysmotility, and positive centromere antibody. Pulmonary involvement of pulmonary involvement of systemic sclerosis are two major manifestations: pulmonary arterial hypertension and ILD. Pulmonary arterial hypertension is the pulmonary expression of widespread vasculopathy. It is more common in limited SS, aka CREST syndrome, sharing the same pathophysiology of the distal ischemia and renal crisis. And ILD result from alveolar basement membrane inflammation and fibrosis. It is more common in diffuse. So ILD for diffuse, ILD, diffuse, which causes more extensive visceral organ scarring. Pulmonary function test. Pulmonary function tests can distinguish between them. Both can cause reduced DLCO. Reduced DLCO despite normal lung mechanics indicates an isolated vascular problem. Therefore, this patient likely has SSPH in which systemic sclerosis, pulmonary arterial hypertension, in which uh, vessel wall thickening can lead to luminal narrowing. Vessel wall thickening can lead to luminal narrowing and elevated pulmonary vascular resistance and eventual right ventricular failure. In contrast, SSILD will produce restrictive pulmonary function tests due to alveolar basement membrane fibrosis causing loss of lung compliance. ILD also present with inspiratory crackle, reticular infiltrate on chest imaging versus clear breath sounds or normal parenchyma on chest X-ray. Okay, okay, we can study tomorrow.